Okay, so we'll talk a little bit about the anatomy of the urinary system. We'll talk a little bit about the normal functioning of the urinary system. We'll talk about some disease processes that can affect the urinary system as well. And I'm going to talk just briefly today. We'll only probably take lecture for about an hour today, just to kind of give you a general overview of the kidneys, the anatomy of the kidneys, and some of those aspects that I just talked about. The kidneys themselves are basically anatomically set up with two structures. You have two kidneys. Both lie in the retroperitoneal area of the abdominal cavity. They are recessed. The superior poles of both of the kidneys lie just inferior to the margin of the ribs. Actually, the lower ribs typically would cover the superior aspects of both of the kidneys. But then the primary body of the kidneys are typically covered by fat pads in the back, and then the abdominal organs and abdominal tissue anteriorly typically will protect the kidneys from the anterior direction. Two kidneys, two ureters. Ureters are the tube-like structure that leads down from the kidneys, and then one urinary bladder, and then one urethra, which again, this is a tube-like structure that leads from the urinary bladder out to the external environment. This just is an illustration, again, taken from your textbook, that demonstrates to you the positioning of the kidneys, again, lying in a retroperitoneal location. As you can see, the superior poles of both of the kidneys are typically protected by the ribs. Again, this being on a posterior view, so an anatomical position where the arrow is at is on the right kidney, the other is on the left kidney. You also can make one noticeable difference between the two kidneys. One typically sits a little bit lower than the other one, and typically in size, one kidney is probably a little bit bigger than the other one. The other thing to note is where the blood supply comes off, and we've already talked about the circulatory system, but specifically when we talk about the kidneys don't have a redundant blood supply. In other words, most of the other organs that we talk about get blood supply from more than one artery. The thyroid gland, for example, if you remember, receives blood supply from a superior thyroid artery and an inferior thyroid artery. The stomach, for example, receives blood supply from gastroepiploic arteries, both lying on the greater curvature of the stomach and the lesser curvature of the stomach. So there's redundant blood supply for all of those organ systems. For the brain, the circle of Willis supplies blood supply to different areas of the brain. If one side of the circle of Willis is cut off, it has a redundant blood supply, so blood supply will come from a different area. The kidneys don't have that luxury. The kidneys have a renal artery. Renal artery comes off the aorta. It supplies the left kidney, and a renal artery supplies the right kidney. If an obstruction occurs in the renal artery, there is not a redundant blood supply. So that kidney would not have blood supply, and that kidney would die. Same thing applies to the left kidney as well. So there's not a redundant blood supply. One renal artery for each kidney, which supplies the primary blood supply. And again, comes off the aorta. And as you can see, the left renal artery is superior to the right renal artery, and that's in the anatomical position. You also on this photograph have a sectional view, and you can see the location of the kidney again in the posterior in the retroperitoneal cavity. As you can see, it's coated and surrounded by fat pads. You see that both anteriorly, and you also see it a bit posteriorly, and then you can see that the muscle region provides the degree of protection from the posterior aspect of the kidney. Anatomical position, again, retroperitoneal location. There's also a fibrous capsule that surrounds the kidney. So in the event of infection in the kidney, typically it's localized to just one kidney. It's an isolated region, does not affect the other kidney, so typically abnormalities in one kidney do not affect the kidney on the opposite side. Also, because of the fibrous capsule, infections are typically localized in that region and won't spread out to adjacent tissue structures because the fibrous covering would keep that infection inside. Also in renal cancers, individuals that suffer from renal cell carcinoma, typically that cancer, as long as it remains inside that kidney and does not invade and migrate outside the fibrous capsule. Typically, if you remove that one kidney, you have cured that patient of cancer because the kidney lies within a fibrous capsule. So there are certain advantages to the fibrous capsule in the kidneys, one of which obviously is protection, but also to localize disease processes. Again, as I already mentioned, the superior portion of the kidney is typically protected by the ribs. Now, the kidney is also broken down anatomically into a cortex and medulla, just as we talked about with the adrenal gland. Cortex is the outer layer, which has the majority of the functional units of the kidney, referred to as the glomeruli. And then the medulla, which is the intersection of the tissue, consists primarily of the tubules and the collecting ducts in the kidneys as well. Again, the medulla, the tubules, the collecting ducts, the renal pelvis, the calyces, these are the structures through which urine will flow. They will flow through this collecting system into the ureters. The ureters are the tube-like structures that lead from the kidneys and lead down into the bladder. The glomerulus, which also consists of, which is also another structure that we'll see in the kidneys, and we'll discuss a little more in detail later on, consists of a capsule. The capsule is surrounded by a network of capillaries. Now, it is very important that the kidneys receive a blood supply. All the blood, the significant portion of the blood pumped by the heart travels to the kidneys, and this blood supply is passed through the tissue of the kidneys itself, goes through a filtration process. Fluids and electrolytes are secreted, absorbed, and reabsorbed in this process, and in the same process, a significant amount of filtering takes place. So again, as we look at the function of the kidney has two primary functions. First of which is filtration, second of which is reabsorption. So a large volume of fluid, including waste products, nutrients, electrolytes, and other dissolved substances pass from the blood into the tubules. The cells and the proteins remain in the blood. The filtrate flows into the tubule system, and then in this tubule system will be where a process of reabsorption will take place. This is essential to maintain adequate balances of fluids and electrolytes. Nutrients, water, and electrolytes all will be reabsorbed in this area. There will be secretions of certain waste products, and secretions of certain electrolytes will occur as well. So some electrolytes are lost in this process. In the collecting ducts, we'll see the transport of urine into the renal pelvis, and then eventually through the eventually out of the kidneys into the surface of the ureters and into the bladder and then out the urethra. Now, the tubules themselves of the kidneys are broken up into three parts. There are proximal convoluted tubules. There is a structure referred to as the loop of Henle that I believe I have on the illustration coming up, and there is a distal convoluted tubule as well. And each of these tubules has a particular function. You'll need to appreciate what each of the functions of each of these aspects of the collecting system involve. Most of the water that is reabsorbed in our system into the blood occurs in the peritubular capillaries. Water is reabsorbed by a process referred to as osmosis, and I know all of you are familiar with the term osmosis now. Reabsorption of glucose and other nutrients and some electrolytes also take place in this area, the proximal convoluted tubule. And then reabsorption in these particular molecules involve an active transport median and also a co-transport median as well. Excessive amounts of glucose in the filtrate is not all absorbed, and then you can see glucose in the urine. Now, glucose in the urine is an abnormality. When we see glucose in the urine, first thing we consider is whether the person may or may not be a diabetic. Glucose is typically not in the urine. Now, there are some abnormalities by which you can see glucose in the urine, and it would explain it other than diabetes. For example, if you collect a urine specimen and the person is having blood in the urine, they may have an active infection in the kidneys that's causing the loss of blood. Red blood cells are being destroyed. The person actually has blood in the urine. Now, inside red blood cells, glucose exists. And so because these red blood cells have lysed or have ruptured and they are now inside the urine may have a small amount of glucose because red blood cells have been damaged. Also, if you collect a urine specimen from a woman who's on a menstrual cycle, you get blood in the urine. That blood has glucose inside the red blood cells. So now that's inside the urine also will have glucose in the urine. Also, individuals who are not drinking an adequate amount of fluid causes the urine to be highly concentrated, and even a small residual amount of glucose that typically would not show up in a urine specimen may be measured at that point because of the concentration of urine. So there are some states by which you can still see glucose in the urine, but primarily even heavy amounts of glucose, people who eat tremendous amounts of sweets, as long as they're producing adequate amounts of insulin, they're not a diabetic. Typically, we do not see glucose in the urine, and when you do see glucose in the urine, it makes you suspect of diabetes, and further studies would be required. Now, because we just talked about the endocrine system, I just want to view a few hormones that are key involved in the kidneys and the functioning of the kidneys, and especially when we talk about the reabsorption of fluids in the kidneys as well. One of those hormones is referred to as antidiuretic hormone. You already know that's secreted from the posterior pituitary gland, controls the reabsorption of water by altering the permeability. Now, this is where antidiuretic hormone will work. It will alter the permeability of the distal convoluted tubule and the collecting duct of the kidney. Now, antidiuretic hormone is, just as the name says, antidiuretic, so water is thus reabsorbed and not excreted from the system. Another hormone that we see, and we've already discussed, is aldosterone. This is secreted by the adrenal cortex, controls sodium reabsorption and water by exchanging sodium ions for potassium ions and hydrogen ions in the distal convoluted tubule. We'll see next week when we talk more about acid-base balance, you'll see why the exchange between sodium ions and the hydrogen ion concentration in the serum leads to a decrease in the pH of the body, makes the body more acidic, and you'll see where this exchange is important and why the kidneys are so important in regulating the hydrogen ion concentration, which essentially regulates metabolic acidosis and alkalosis. The other hormone that's important is, and let me just finish with aldosterone by saying, also when aldosterone, because you reabsorb sodium, remember water will follow sodium, and so if you see the reabsorption of sodium, you will also see reabsorption of water. Now, another hormone that's secreted is atrial natriuretic hormone. And this is basically a third hormone. It's involved in fluid balance. We touched on it a little bit in the endocrine system. We see it a lot in the cardiovascular system in maintaining volume and pressure, but another hormone that's effectively involved in reabsorption in the kidneys. Now, I alluded to circulation a little bit earlier. Again, both kidneys get an isolated blood supply from either the left renal artery or the right renal artery, but 25% of cardiac output enters the renal arteries from the aorta. So the kidneys are essentially processing a quarter of our blood supply at any given time. That's a significant amount of blood supply that has to go through the kidneys. Renal arteries pass through the renal pelvis. They will divide several times during this passage to provide not only blood supply to the kidneys themselves, but also in this process of reabsorption and filtration as well. And again, my point being, there is no alternative blood supply for the kidneys. The kidneys do not have a redundant blood supply as we see in some of the other organ systems. And so if you obstruct the blood flow, you can cause complete destruction and loss of the kidneys themselves. Without blood supply to tissue, there's a lack of not only blood supply, oxygen, and nutrients. And so when that occurs, you get significant tissue destruction and loss, leads to first ischemia, then infarction, and then necrosis. So no alternative blood supply for the kidneys. Kidneys also are broken into, or break down into various branches. Again, the renal arteries will typically lead into arterioles, two sets of capillaries in each of the nephrons of the kidneys. We have arterioles into the kidneys that are separated into two branches. One is afferent arterioles and efferent arterioles, which supply blood to the capillary system inside the kidneys. The arrangement of blood supply in the kidneys is unique because the blood from the glomerula and the capillaries flows into another arteriole. This is referred to as the efferent arterioles, and so afferent arterioles will bring blood into the efferent arterioles. This will be important, as we'll describe later, as far as the effective functioning of the kidneys and their ability to be able to sense pressure in the body or in the system. So the kidneys, because of the way the arterioles are set up, allows the body to regulate its blood pressure based upon the kidney's ability to sense the pressure. The afferent blood vessels send the signal to the efferent vessels that there's not adequate blood supply. Then you'll see the kidneys will secrete an increased amount of antidiuretic hormone. They'll secrete significant amounts of aldosterone, which in turn will reabsorb more fluid. Antidiuretic hormone will prevent the loss of any further fluid. Aldosterone will increase sodium reabsorption, which will entail make the kidneys reabsorb more water and fluid, which will elevate the volume. If you elevate the volume, you elevate the blood pressure. And so we'll see how these systems can work together. The other reason why we'll see these two types of arterioles, again, an afferent arteriole and an efferent arteriole, purpose of this is also to help to control the pressure inside the glomerular capillaries itself, which will in effect help to control the filtration rate that takes place as well. Remember, blood as it comes into the kidneys also will be filtered. The rate of this filtration is determined by the dual arteriole effect of both the afferent and efferent arterioles. Pressure determines the rate. Constriction and dilating arterioles restrict the amount of blood that actually enters into the kidneys or enters into the capillary matrix, and it's adjusted and maintained dependent upon what the reading of the systemic blood pressure. And so you'll see how these two arteries will intermix later on in the lecture. The degree of constriction in the arterioles, if the afferent arterioles, which is the first branch of the renal artery as it comes into the kidneys, if they are dilated and the afferent arterioles are constricted, hydrostatic pressure, remember, is that force by which you'll see water being brought into these into the glomerular system. And you'll see the pressure in the glomerular capillaries will increase, and the glomerular filtration will increase as well. So think about that again. Afferent arterioles, the first chain of that, is dilated. Blood vessels are dilated. Typically, the pressure is lower. If you think about blood vessels as a water pipe, if you have a big water pipe, dilated, lower pressure. Tight, small water pipe, more pressure. And so if the afferent arterioles are dilated, it sends the signal to the efferent arterioles, which will constrict. When they constrict, that increases the hydrostatic pressure inside the kidneys, which will make the kidneys reabsorb more fluid. This will affect the systemic pressure, and the afferent arterioles are reflective of what's going on in the systemic system. Three factors will control the degree of constriction that we'll see in the blood vessels of the kidney. One is a local autoregulation. The other is the sympathetic nervous system, which we'll talk about in a couple of weeks now. But the sympathetic nervous system, two parts of the autonomic nervous system, parasympathetic and sympathetic nervous system, and we'll see that's primarily controlled, or one of the primary control factors of the urinary system. There's also the renin-angiotensin mechanism that you've already kind of studied when we talked about the endocrine system. The renin-angiotensin system, important part of the kidneys in that it affects the ability of the blood vessels to constrict, to vasoconstrict in the system. The term autoregulation refers to a local reflex which adjusts the diameter of the arterioles. This is made in response to even minor changes in blood flow to the kidneys. Kidneys are very sensitive in regards to blood flow. You will see in priority organs, the cardiovascular system, the neurological system, extremely important in maintaining blood supply, oxygen supply, and nutrients. But the third system in that are the kidneys as well. The body will defer blood supply to the kidneys, to the heart, and to the brain at the demise of other organ systems, because those systems are vital for function. It will take blood away from the GI tract. It will vasoconstrict blood in the peripheral tissues and shunt blood to the kidneys because the kidneys have to be able to get blood supply. One of the key clinical indicators that we have in volume in an emergency room setting is to follow a person's urinary output. One way that we know whether the person has adequate blood volume, a person comes in from a car accident, significant bleeding, and you want to know whether the person's in shock or not, one of the first procedures that's done is to put in a urinary catheter because you want to make sure the person is continuing to produce urine. If the person is continuing to produce urine, then you know the kidneys are getting adequate blood supply. If the kidneys are not producing urine and there's no measurable urine, then that means not only do you not have adequate blood supply to the kidneys, but it means that the person is not perfusing. The heart's not beating well, the heart doesn't have an adequate amount of volume, and everything is maxed out inside the kidneys. You see heavy secretion of antidiuretic hormone, you'll see significant secretion of aldosterone because the kidney now is trying to preserve all fluid and will not excrete any fluid to that effect. If the kidneys stop making urine, then the kidneys will fail. And so very important, this auto-regulation mechanism. Also, the sympathetic nervous system, again, a part of this vasoconstriction that we talk about in the arteries. Sympathetic nervous system increases vasoconstriction inside the kidneys, so both arterioles will be stimulated at the same time to produce this effect. The other hormone that's produced, again, and I know you studied this a little bit in the endocrine system, is renin. Renin is secreted by particular cells in the kidneys, the juxtaglomerular cells of the kidneys, and so when blood flow in the afferent arterioles are reduced, renin levels can determine whether this mechanism are a factor in hypertension. So we see a series of enzyme reactions that will take place. Renin acts on a plasma protein angiotensin and produces angiotensin II. Angiotensin II is a very powerful systemic vasoconstrictor. So again, this is an automatic response that you'll see take place in the kidneys that will help in the physiologic functioning of the kidneys. Blood flow to the kidneys is seriously impaired when blood pressure drops, and that's why the kidney is so sensitive to the blood pressure in the system and why the monitoring phase, the afferent arterioles in the kidneys are so important. So when the blood pressure drops, both the sympathetic nervous system and the renin-angiotensin mechanism will both be activated to restore blood pressure and blood flow to vital areas. Now, angiotensin. Angiotensin, we also touched on a little bit in the endocrine system as well. Angiotensin causes systemic vasoconstriction. It stimulates the secretion of aldosterone, which increases the reabsorption of sodium and water. So I'll repeat that again. Angiotensin, important that you recognize the functioning of it, causes systemic vasoconstriction. It also stimulates secretion of aldosterone. Aldosterone, remember, increases the reabsorption of sodium. You reabsorb sodium means you also reabsorb water. Person is markedly hypotensive, you see this mechanism take place. Just mention real quickly, because of angiotensin, there's an angiotensin converting enzyme that converts angiotensin to angiotensin II. There are medications that are out there that are available that control blood pressure based on their ability to stop the conversion of angiotensin to angiotensin II. Remember, angiotensin and angiotensin II are powerful vasoconstrictors. In some individuals who have blood pressure problems, if you can affect the control of that enzyme, remember enzymes carry out reactions, if you can block that reaction and stop the production to a degree of angiotensin II, you can control blood pressure. And so there are a number of medicines that are out there now that are available that are used to treat it. They're called ACE inhibitors. You may be familiar with that term. ACE inhibitors are angiotensin converting enzyme inhibitors, which will prevent the conversion of angiotensin to angiotensin II. And these are just some common names. The prils, when you see a medication that ends in IL, typically captopril, monopril, lisinopril, enalapril. These are types of, that should be an A there, enalapril, N-L-A-N-A, sorry about the typo, which will control blood pressure. So blood pressure, and my point in that being, blood pressure is very closely related to kidney functioning. Frequently we see patients that have kidney disease also have hypertension, Hypertensive patients typically have kidney disease. There seems to be a direct correlation between the two, and still significant studies are being done now to try to determine what that relationship is. Frequently we see blood pressures in the afferent arterioles will decrease, and then the renin-angiotensin-aldosterone triad would be stimulated to be able to effectively manage blood pressure. Now, kidneys produce a filtrate, which we refer to as urine. This is a filtrate that's processed in the tubules and the collecting ducts of the kidneys. Urine basically is transported, and you should know the route of transport for urine goes initially through collecting ducts, the renal calyces, the ureters, and then to the urinary bladder. You already know the epithelial tissue that lines the collecting duct, that lines the bladder. That's the transitional epithelial tissue. We also see transitional epithelial tissue in the renal pelvis, in the calyces, the ureters, and the bladder as well. A specialized form of cuboidal epithelial tissue, not permeable to water. It resists irritation and the constant contact with urine, which typically has a significant amount of filtrate that can be irritating, but transitional epithelium is specifically designed to be able to tolerate that. Urinary bladder is also composed of smooth muscle. We also see folds of rugae, similar to what you saw in the stomach, where you see the smooth surfaces. Now in the bladder, it's because it has to be an expandable sac. The rugae in the gastrointestinal system is there to help in mechanical digestion and also to increase the surface area. But when we talk about the urinary bladder, the openings of the two ureters, when we talk about the urinary bladder in the rugae folds, it's basically because we have a structure that needs to expand to hold a volume of urine, and then needs to be contracted when the bladder is empty. The bladder itself is located in the retroperitoneal area, just as we talked about with the kidneys. Opening of two ureters bring urine to the urinary bladder, take it out the outlet, the urethra. There is a triangular section that's measured, and it's the points of the two ureters as they come down to the urinary bladder, and then the ureter as it leads out of the urinary bladder, that basically makes a triangle that's referred to as the trigone. Anatomically, and you may remember this from the reproductive system, the female urethra is significantly shorter than the male urethra, about 3 to 4 centimeters in length. Short, wide, it opens to the peritoneal area in front of the vagina and the anus. The proximity of the female urethra promotes urinary tract infection. The male urethra in the urinary system is longer. It's about 20 centimeters, passes through the head of the penis and passes through the prostate gland, which is located at the base of the bladder, and transports both a dual role in reproductive and urinary because it passes both semen and urine. And that's just a little tidbit on the urinary infections. Again, I know we went over that in the reproductive system. Infections typically will ascend the urinary bladder, and so in infections that affect the urethra, typically through bacterial growth, these organisms will migrate into the urinary bladder. Urinary bladder, though the electrolytes and waste products that we excrete from our system are waste products, for bacteria, it's a great nutrient source. So if bacteria is able to grow and migrate into the urinary bladder, then you'll see aggressive proliferation of bacteria, which not only will ascend through the urinary bladder, but then will also ascend up the ureters and actually can infect the tissue of the kidneys themselves. So because of the mucosal lining, because of the moisture and the amount of substances, the waste products that enter into the bladder, bacteria can grow from that. Now, as I told the class before you was a microbiology class, we talked about urine, and urine essentially is sterile. Urine should be sterile unless there's an infection. Any bacteria in the urine is considered to be an abnormality. Now, there are certainly degrees of urinary tract infections. If you're not over 100,000 colonies of bacterial growth, then typically that bacterial infection is not felt to be clinically significant. Greater than 100,000 colonies is felt to be clinically significant, and certainly steps would need to be taken to alleviate that infection, whether that's from administering antibiotic therapy, increasing fluid intake if you felt it's from stasis and just because the urine is not passing out quickly enough. But typically, some type of intervention would need to take place if bacterial growth is over a certain point. And this is the male urinary system, the lower urinary portion of the system. Again, ureters coming down from the urinary bladder. This is a lateral view, so there's a ureter on the other side as well. The urinary bladder, and then the urethra, as you can see, passes through the prostate gland, and then the common passageway here from the seminal vesicles also causes to be a passageway for both urine and for semen. Well, I thought I had one in the female system. I guess it's coming up. The process of urination in the urinary system is referred to as mituration, urination and or voiding. The reflex is basically stimulated by increased pressure in the bladder. It's affected by the parasympathetic nervous system, the nerves extending from the sacral portion of the spinal cord, external and internal iliac sphincters of the bladder and the pelvis diaphragm have to relax. Bladder muscles have to contract, and the bladder will basically empty. Now, this is a learned response. So typically, we learn bladder control in infancy. Control becomes earlier in some, later in others, depending on the individual, but this is a learned response. Now, incontinence relates to the loss of this voluntary control of the bladder. Young children learn this voluntary control, as I've already alluded to, but in some conditions, as an individual matures, either from disease abnormalities, for example, prostatitis can occur. Individual has recurrent prostatic infections. This affects the process of the sphincter on the urinary bladder, and so under stressful situations, person sneezes, person coughs, person laughs, or the bladder gets full and the sphincter control has been lost, person may have what's referred to as stress incontinence, especially in the case of increasing intra-abdominal pressure. You cough, the intra-abdominal pressure, you tense your abdominal muscles and it increases the intra-abdominal pressure. You sneeze, increases intra-abdominal pressure. In women, we can see this effect from multiple pregnancies. Multiple pregnancies placing increased pressure on the urinary bladder, which puts increased pressure on the sphincter. Typically, the sphincter can tolerate that, but under certain conditions, with multiple pregnancies, there can be a laxity in the sphincter muscle control, and so the person would have what we refer to again as incontinence. Now, elderly patients or patients who have suffered strokes also may have compromise in the nerves that stimulate or innervate the urinary bladder and the sphincter, and so in that type of damage as well. So when we say spinal cord injuries and or brain injuries, we're talking specifically about conditions that have compromised the innervation of these organ systems. Then retention of urine. This is an inability to empty the urinary bladder associated with flow incontinence. Sacral level of the spinal cord can be injured, and we'll see urinary retention, and are some types of anesthetic agents. We used to use atropine quite a bit for a pre-anesthetic because it dried up secretions. One of the problems associated with it, though, was urinary retention, so the person would come out of surgery and would be unable to urinate. The other part of anesthesia is anesthesia relaxes smooth muscle. Remember, the urinary bladder has smooth muscle, so the anesthetic has relaxed the smooth muscle, and the smooth muscle for a period of time may forget how to work. And patients who have severe cases of urinary retention, especially if it's related to surgery or something like that, those individuals have to actually go through bladder training, which means they have to have a catheter inserted, and you actually allow the bladder to fill up, and then you unclamp the catheter, and then you ask the patient to forcefully bear down on their abdomen, or their abdominal muscles, which would stimulate urine. And you basically are exercising the bladder, so the person would have to be trained in severe cases. Most of the time with anesthesia, typically time is a factor, and so once the anesthetic agent has completely worked out, that will return. But obviously in cases like of sacral spinal cord injuries, and the patient has incontinence. These patients can be trained in some cases to be able to have control of the bladder again, but in many cases they cannot and would have to perform self-catheterizations for the possibility of urination. Now, and then the end product of the kidneys is the production of urine, and just want to touch upon just a little bit about the constituents of urine that's produced from the kidneys. In urinalysis, typically what we look at in a laboratory setting would be able to look at the normal appearance of urine. Urine typically is clear, straw-colored, has a mild odor to it. However, that will depend on the concentration of the urine. Now, the urine should be clear, so heavily concentrated urine typically is a dark yellow in appearance, maybe amber in appearance as well, depending on the hydration level. You see a wide range of pH. The pH in the urine can range from 7.45 to 8. That's from an acidic level to an alkaline level. And you see these wide variances in the urinary pH because when we talk about acid-base balance next week in its relationship with the kidneys, you'll see that the kidneys are important in being able to regulate bicarbonate secretion and hydrogen ion excretion based upon what the body's needs are. In cases where the body may be generating a metabolic type of a process, tremendous amount of lactic acid is being produced in the body. Lactic acid is produced when the body needs additional energy sources. Glycogen is being broken down. The problem with lactic acid is very acidic. The kidneys, one of the kidneys' responsibilities would be able to get rid of the lactic acid to keep the body pH within a normal range between 7.35 and 7.45, and to do that it would have to excrete more hydrogen ions, which would affect the urinary pH. Now, that's a normal process, and so you'd have a very acidic urine. But on the other hand, in a metabolic acidosis or metabolic alkalosis where the pH is high, you might see more bicarbonate being excreted in the kidney, which would lead to a higher pH level of around 8. You also will see in the case of infection in the urine, when you have a significant amount of bacteria, the urine will change in appearance and will become more cloudy. Large amounts of proteins in blood and even pus in the urine will lead to a cloudy appearance. And then the dark urine, hematuria, blood in the urine, bilirubin or bilirubinuria is a condition where you see the blood in the urine or bilirubin spilling in the urine. And then obviously the odor of the urine is important. Typically it would be a mild odor, but in cases where you see a very strong or foul odor would be indicative of a urinary infection. And these are just some terms that you see when we're describing urine that's produced. Again, typically normal urine is clear as an appearance. Typically normal urine does not have significant amount of red blood cells. There may be a few red blood cells, but typically not many. You typically don't see protein in urine, and you typically don't see glucose in the urine. So these terms, hematuria refers to blood in the urine, proteinuria refers to protein in the urine, bacteria or bacteriuria or pyuria is a term that refers to pus or infection in the urinary tract. Another term referred to as urine cast, and I'm going to post this for you on your lab to be able to look at. Urine cast are actually the covering of the cells. If you have red blood cells and they rupture, you would get basically just the cell covering, and that's sloughed off and that's left in the urine, and it's measured as urinary cast. It's usually indicative of a destructive process which is going on in the parenchyma of the kidneys itself, in the kidney tissue itself. When you lose a significant amount of cells, you start to see these moles of cells or moles of the tubules of the kidneys. And then there's the specific gravity, which lets you know the concentration of the urine. That's sometimes important if you're trying to find out if an individual has a primary kidney disease or not. But remember, the concentrations of the urine can vary based upon what the body's needs are. For example, the person is hypotensive or has a low blood pressure, then aldosterone is going to be secreted, angiotensin is going to be secreted, antidiuretic hormone is going to be secreted, and so water is going to be reabsorbed by the kidneys and not excreted. what little urine is produced is going to be significantly concentrated, so the specific gravity may be very high. The body may have compensated, and so the body's osmolarity may be normal, but it's normal only because the kidney is doing its normal function. But so you may get these wide variances in specific gravity as well. High specific gravity typically indicates, though, that the person is dehydrated. The urine osmolarity, though, should be compared with the serum osmolarity. Person has been you go fishing all day, you didn't take water with you, or you get lost out on your fishing boat, you get very dehydrated, and you start drinking the seawater, you get extremely high specific gravity because your urine becomes very concentrated, because the salt water then makes you reabsorb even more water because it changes the serum osmolarity as well. So now, if you're very hydrated, if you're drinking plenty of water, you're drinking your 8 glasses of water a day or more, then the specific gravity tends to be very low. And then there are specific blood tests that help us to look at renal functioning. Specific blood tests include elevated urea levels. We call this blood urea nitrogen. Elevated BUN, creatinine. Creatinine is another substance that can be measured. Creatinine is the reflection of the excretion of nitrogen. Now, in the liver, when you talked about the digestive system, in the liver, remember, ammonia is produced when we use protein as an energy source. When protein is produced as an energy source, you see a process called deamination take place. From the protein, ammonia is removed. We can't use ammonia in our metabolism. And ammonia is processed in the liver. The liver will break down ammonia into urea, and urea is then sent to the kidneys for excretion. Urea is basically a harmless substance. And so it's easily measured in the urinary system, or in the urine, to be able to determine not only normal functioning of the kidneys, but also to determine normal functioning of the liver. And so in cases where you want to measure adequate liver function, you want to measure the urea, blood urea nitrogen, and then you also want to look at the creatinine as well. If those numbers are elevated, it typically reflects abnormalities in the functioning of the kidneys. And those numbers are usually pretty low. BUN and creatinine is usually 1 and 0.1 respectively. And so if you see elevations in those numbers, it's typically indicative of kidney disease or dehydration. Process that we'll talk about next week, and I'm not going to go into a lot of detail about now, is metabolic acidosis, metabolic alkalosis, but I'm not going to talk about that a lot now. We'll talk about that more next week. And then anemia can occur based on the kidneys because of the production of erythropoietin. Again, you already studied this last week, and those of you who have tested already may have already been tested on erythropoietin, but this is one of the substances that's produced in the kidneys. It affects the bone marrow. It stimulates the bone marrow production of red blood cells. So if you have anemia, there may be an indication of the person not producing an adequate amount of erythropoietin. Individuals that suffer from kidney disease, abnormal kidney functioning, are not producing an adequate amount of erythropoietin and will lead to anemia. Also, you can measure electrolyte functionings. Remember, again, sodium reabsorption takes place inside the kidneys. The loss and reabsorption of potassium takes place in the kidneys, so the measurement of those electrolytes may be reflective of the functioning as well. Some other specialized tests for the kidneys as well. Culture and sensitivities can be done to assess the urine that's produced from the kidneys. There are certain types of clearance tests that can be done to make sure that the kidneys are adequately filtering out the blood and getting rid of the byproducts. There are specific X-ray studies that can be done. IVP refers to an intravenous pyelogram, which is the injection of a contrast dye that actually inject those into the kidneys, and you look at the structure of the kidney itself. And then an MRI, which is a specialized radiographic study that can look at the tissue of the kidney specifically in a three-dimensional way. Cystoscopy refers to a procedure that you visually look at the lower urinary system. beginning with the urethra and the urinary bladder, and sometimes up as far as the ureters, but typically to look into the kidneys itself is not possible through those. But cystoscopy typically refers to a procedure that looks into the urinary bladder. And then another specialized test would be biopsy. Two other points that I want to make too before we end today. One is edema, localized edema, also associated with functioning of the kidneys. Now this is important in a couple of ways. Edema typically occurs because of decrease in hydrostatic pressure. Now there is hydrostatic pressure that increases, which will push fluid out of the system, and then there is osmotic pressure that will actually draw fluid into the blood vessels and get rid of edema. Now the kidneys are responsible for spilling protein or losing proteins. If you see protein in the urine, it means that the system, for some reason, either the kidneys themselves or in the system itself, is losing protein. If we lose a tremendous amount of protein are one of those substances inside the serum that allows that draws fluid from the tissue. If you lose protein, you lose fluid out into the peripheral tissue. If you want to get fluid out of the tissue, you have to put more concentration of solute inside the blood vessels, and to do that you need protein. And so if the kidneys are losing protein, then typically the person will experience edema, or a significant amount of edema. And so we see the kidneys are very important physiologically in maintaining edema. And then finally, the excretion of waste. Again, important in the urinary system for eliminating waste products from the body. This is the filtration process that we alluded to earlier about getting rid of waste products throughout the system. Okay, that'll end it for today. Next week, we'll go more on the anatomical structures of the kidneys. We'll talk more about acid-base balance of the kidneys. And then the test will be in the following week. Got that right? Do I have that right? Yeah, in the following week for that. Okay. That's